Hello, my name is Mindy Haro. I'm a radiologist and I work in Philadelphia in Pennsylvania at the Einstein Healthcare Network. And it is my pleasure today to speak with you about fulminant liver failure. The outline for my talk today is as follows. First, we'll talk about the definition of what this entity actually is, something about the incidence and causes, as well as the clinical features. There are three types of acute liver failure, which is very important for imaging, and we will discuss those as well. As far as imaging goes, much of this, in fact, most of it is done by ultrasound with some CT and occasionally some MR, and we'll show some examples. In addition to general imaging of acute liver failure, we'll also touch upon some specific clinical situations and etiologies for which imaging is very helpful, as well as some other minor issues. Fulminant liver failure is the traditional name for the entity that we'll be discussing, but of late it has been changed and is now known as an umbrella term of acute liver failure, which is how we will refer to it for this talk. The entity is the sudden onset of hepatic encephalopathy in an otherwise healthy person, so quite a dramatic event. Because it is liver failure, it is typically associated with coagulopathy, jaundice, and may very rapidly progress to multi-organ system failure. The subcategories of acute liver failure have to do with the interval between the onset of jaundice and encephalopathy. This can be very, very rapid, and that would be the hyperacute stage, which occurs within 1 week of the incident, whatever that might be, that causes the liver failure. These patients, as sick as they may be, and they are very, very sick, generally have a better outcome. Patients who are referred to in the acute phase of acute liver failure generally present within the first 3 to 4 weeks of the inciting cause. Sub-acute is the category in which this occurs within 3 months of the inciting cause. How common is this entity, which perhaps you may or may not have even seen a patient of? There is no specific medical code or registry or surveillance system, so it is a little bit difficult and there are only estimates. These estimates come from centers which have liver transplant programs because many of these patients are transferred to such centers for their care and often for liver transplants, and so all of the information we have comes from single hospital reports. The estimates are between 2,300 and 2,800 of new cases in the United States per year. The overall annual death rate is 0.1%, which actually is fairly significant for this relatively rare entity, and it counts for 6% of all liver-related deaths. In addition, for a fairly uncommon entity, it accounts for 6% of adult liver transplants. As far as the causes, what we're talking about, this acute fulminant liver failure, that is the final common pathway for many etiologies. And the inciting cause has a lot to do with the geographic location of the patient and the time period of their liver failure. In the United States, drugs and toxins are the most common etiologies for fulminant acute liver failure, accounting for nearly 60%. Of those, acetaminophen is the most common drug that we know of. Many are considered idiosyncratic, which of course just means we don't know what caused it, and mushrooms, wild mushrooms, are also a cause. In the rest of the world, viruses are a more common cause of acute fulminant liver failure. There are a whole laundry list of other causes, some of them relatively rare, as you can see here, various entities which cause just ischemic hepatocellular injury can cause fulminant liver failure, as well as fatty liver of pregnancy and Wilson's disease. There are various miscellaneous causes, as you can see, which we'll also discuss a few of these, and of them, autoimmune hepatitis is probably somewhat more common than many of the others, and people think that may be the etiology for some of the idiosyncratic causes. We just are unable to prove it. Indeterminate causes include primary graft non-function in liver transplant patients. As I said again, acetaminophen is the most common cause of fulminant liver failure in the United States and also the most common cause of hyperacute liver failure. What kinds of outcomes do these patients have? Well, this is the issue here. In the short term, 3 weeks from the diagnosis, there's about 2/3 survival, which means 1/3 of patients will die in this time period. If they need a liver transplant, this usually is rapidly apparent and occurs within a few days of admission, and death often occurs within a week of admission when it's going to happen. Overall, about 64% of these patients will survive without a liver transplant. This is a very, very serious illness. And survival does not necessarily mean that their liver is in good shape. It just means they survive the acute phase. Of those patients who receive a liver transplant, the survival rate at 1 year is in the 74 to 84% range. If you know about liver transplants, this is actually lower than in the United States because these patients are so sick when they receive their liver transplants. The key thing for the clinical physicians caring for these patients is to make a very as rapid as possible determination of whether to list the patient for a liver transplant. If medical therapy is too prolonged, the patient may not become suitable for a transplant. They may be so sick because of multi-organ failure and sepsis. There is an association in the United States for liver disease, and they have a whole set of guidelines for these patients in terms of diagnosis, evaluation, and monitoring, as you can see here. If you look down the list of things that they consider or do for these patients, you'll notice that there is no specific imaging recommendation. That does not mean that these patients aren't imaged. I can guarantee you they all are, and there are specific things that we need to look for, but it's not on this list. What are the clinical features of these patients? As I said, these are patients who are going to become jaundiced and rapidly progress to encephalopathy. All of the functions of the liver are called into question here, and therefore they have metabolic issues, hypoglycemia, lactic acidosis, coagulopathy, etc. Encephalopathy ensues. The lungs are affected with acute respiratory distress syndrome, high output heart failure, there is suppression of bone marrow, acute renal failure, and a variety of other issues. These, as I said, again, these are very, very sick patients. They are in the intensive care unit and they require rapid and aggressive kind of care. Before we turn to the imaging, I'll actually tell you the story of one of the patients. I happened to see a patient who had survived her hyperacute liver failure and had a liver transplant. She was waiting about 6 months later. She was at our institution there for some reason to see her doctor, and I happened to say hello, and we were sitting and talking. And this is the story that she told me, just so that you understand what happens to these patients. She started to feel unwell one day, thought it was some sort of GI distress or maybe something that she ate. And as the day progressed, she started to feel worse and worse. By the evening, she decided she felt unwell enough that she went to her local community hospital emergency room. She went there with one of her family members, and she remembers being in the emergency room. The next thing she remembers is some number of days later, she woke up in the intensive care unit of my hospital, a different hospital, having received a liver transplant. That's exactly what happened. And it was an overwhelmingly psychological burden for her as well as a health burden. And just to explain the severity of these kinds of patients' illness. So, as I mentioned, there are no specific guidelines for imaging these patients, but in general, the vast majority of them will receive some type of imaging. And that imaging often will be only ultrasound. The reason for this is they are so sick, they are in intensive care units, and we can bring the ultrasound to the bedside. They may not be well enough to even be brought to a CT scanner or an MR scanner. What is the purpose of doing imaging in these patients? One of the major things that we need to evaluate them for is whether the appearance of the liver is that of acute disease or chronic disease. Now, as you'll see, in hyperacute situations, the liver may be fairly normal, but we are very good at figuring out, in general, if it's chronic disease, and you'll see what happens. The pathology of acute liver failure is that there is massive necrosis of the liver, and the whole liver essentially collapses, if you will. Often there are small islands of normal liver left behind, and those can go on and have regenerating nodules in those areas. Regular cirrhosis has lots of fibrosis and also has some regenerating nodules, but it's the fibrosis and the nodular contour that is characteristic. So very hyperacute liver failure, just collapse of the liver, but it may seem normal to us on imaging. Cirrhosis, most people know what that looks like, fibrosis and regenerating nodules. We need to also look at the hepatic vasculature, particularly in terms of portal vein thrombosis and the possibility of what may be needed for transplantation. And while most of these patients, there's nothing that we can say regarding imaging as far as the etiology, there are a few subcategories in which ultrasound or imaging in general can suggest an etiology, and that's very important. In the hyperacute stage, the liver may be essentially normal on ultrasound and CT. In patients who present in the acute phase slightly later, the liver may begin to look somewhat abnormal. There could be areas that are relatively hypoechoic on ultrasound and hypodense on CT. These are felt to be the areas of necrosis. The echogenic areas, which stand out a bit and are higher density on CT, are probably the normal liver tissue. When patients are presenting in the more subacute phase, several weeks or even a month along in their symptoms, again, there will be hypoechoic or hypodense areas of necrosis and more well-defined areas that are echogenic or hyperdense on CT, representing islands of regeneration. Let's turn now to the hyperacute liver phase, those patients who present within 1 week of the inciting etiology. In these patients, the liver contour is smooth. There are generally no findings yet of portal hypertension, such as splenomegaly. The portal vein hopefully will be open, and though we do Doppler, there are no specific Doppler findings. The liver echogenicity is usually normal or could be slightly heterogeneous, which is clearly very nonspecific. One thing that you may commonly see, again nonspecific, but the gallbladder may be quite small. There are not much bile in the gallbladder, and the wall may be edematous. If you look at the kidneys, which you should do, they can be enlarged, and there may be a trace of ascites. So overall, nothing specific, but again, smooth contour and often relatively normal echogenicity. At this stage, ultrasound and other modalities are very accurate to distinguish hyperacute liver failure, fulminant liver failure, from cirrhosis, because cirrhosis will look completely different, and fulminant liver failure in the hyperacute stage looks relatively normal with just minor findings. Let's turn to some of these examples. This was a patient who was admitted in acute hyperacute liver failure secondary to acetaminophen. She was 44 years old, and 1 day after this ultrasound, she had a liver transplant which showed at least 50% hepatocyte necrosis. This is what her liver looked like. I think we'd all admit that the liver parenchyma here looks quite homogeneous and normal. The contour of the liver was smooth. Notice, if you will, the gallbladder, not very distended for an obviously fasting patient, and has a edematous wall. The Doppler was unremarkable. Normal portal flow, normal hepatic arterial flow. A fairly innocuous looking ultrasound, but this patient needed a transplant 1 day later. Here is a second patient, acute liver failure of unknown etiology in the hyperacute phase. The explant on this patient a day or 2 later showed submassive necrosis and some steatosis. In this situation, here is the liver, small gallbladder again, poorly distended. This is the spleen. So this liver was overall a little bit more echogenic than the spleen, but not enlarged, homogeneous, and had a smooth contour with normal portal flow. So the important thing is we would not mistake this for cirrhosis. This is clearly not a chronic liver disease, and that's very crucial information for the clinicians. Turning now to a patient with acute liver failure, now out about a week. It was thought that this patient had her liver failure due to having taken some green tea extract from an herbal source. This liver is a bit different. This one is beginning to look somewhat abnormal. Most of the liver, if you look here, is relatively hypoechoic, and the portal triads stand out a bit. This area right here is a little bit more echogenic. Again, here's another image, hypoechoic, hyperechoic, and this is the spleen in comparison. So if you look carefully, Though you might think the echogenic areas are a nodule or a mass, those are probably the normal islands of liver, and the rest of the liver is hypoechoic. Still, normal size, smooth contour. Again, this explant showed submassive necrosis, a relatively small liver. This patient was found to have acute liver failure secondary to autoimmune hepatitis. The liver was small. This was within a week to two, if you will. Again, some areas of echogenic liver, other areas hypoechoic with the bright portal triads. And already it's starting to be a little bit heterogeneous, you can see, compared to the spleen, which is actually now larger than the liver. The liver has shrunk considerably. Another patient came and was found to have autoimmune hepatitis and acute liver failure, had abnormal liver function studies, as you can see. This patient was a little bit different. The patient presented with jaundice, but no encephalopathy or other organ failure. So not quite into the really fulminant liver range. And if you will, the ultrasound was a little bit different. This liver was large, as you can see. It was a little bit echogenic, but quite homogeneous and a smooth contour. There was ascites, the gallbladder was small, and the wall was thick. This patient, fortunately, had an excellent response to steroid therapy, which is the treatment for autoimmune hepatitis, and improved, did not need a liver transplant. She came back to us 3 years later for a routine abdominal sonogram, at which point the appearance of her liver and spleen looked perfectly normal, as was her liver function. So this is sort of went down the other pathway, didn't quite go to the fulminant stage, and was able to recover with steroids. As I mentioned, autoimmune hepatitis is a cause of acute liver failure. It may be a more common cause than we have known about, and sometimes it's difficult to make the diagnosis because the antibodies and levels may just not really be high enough to determine it. The imaging is similar to the other causes, and the outcomes, as you can see, can go in two different pathways. The severe or fulminant patients may go on to a liver transplant. Those that are not quite as severe respond well to corticosteroids. The problem here is that you need to make the decision about who gets the steroids and who does not. If the patient is in fulminant liver failure and looks like they need a transplant, giving the corticosteroids may actually give them a poorer outcome after their liver transplant because it predisposes them to sepsis, and they do not do as well. Turning now to patients who present in the acute stage of fulminant acute liver failure, so those are patients within 1 to 4 weeks of the initial symptoms. In this group, when you initially image them, you may see an abnormal appearance of the liver. The contour can vary from finely nodular to significantly nodular. There may be a moderate to large volume of ascites. Varices may be seen. The liver can be quite small, and you saw that in some of the acute patients, and there can be mild to moderate splenomegaly. By the time you get to this stage, ultrasound and the other modalities perform less well in distinguishing the patient from cirrhosis, because you're facing a patient who you may never have seen before with a nodular contour and ascites, and the first inclination would be, this is cirrhosis, so you have to be very careful. This patient had an unknown dietary supplement which was thought to have caused her liver failure. She had no prior liver disease and came in quite sick with new encephalopathy. If you look at the liver, it was small, normalish in size, clearly heterogeneous areas of hypoechoic and hyperechoic liver. Over on this image, you can see even more large geographic hypoechoic and hyperechoic areas. Her initial Doppler was fairly normal. The hepatic arterial velocities may be a little bit higher than usual, but good portal flow. She was admitted to the ICU and monitored and treated. 1 week later, so now about 3 weeks after the initial symptoms, she had a significant clinical deterioration. We were asked to re-image, and you can see now a significant amount of ascites, pleural effusion. The liver is even maybe a little bit smaller, and the contour, as you can see here especially, the contour of the liver is now becoming wavy and minimally nodular. This is in comparison to the spleen. There's ascites around the spleen, and there's also a left pleural effusion. definitely a change in appearance of the liver. The Doppler had also changed a little bit. The hepatic arterial velocities were even higher, most likely reflecting the fact that though there was portal flow, there was less portal flow getting in, so concomitant arterial flow had increased. We were able to actually see a paraumbilical vein varix open up, and this patient who had gone into acute liver failure had nephromegaly. It was bilateral, but certainly no hydronephrosis. The patient went on rapidly and received a liver transplant, and this is what the liver that came out of her looked like. You can see that the entire right lobe had a very nodular contour. Just looking at it, you might think it's cirrhosis, but the left lobe was relatively spared. And what we're looking at is, and this is the pathology of it, that the little purple cells are all the areas of necrosis. And this is an island of more normal liver surrounded by all of this necrosis. So the lumps and bumps on the surface there are the islands of the somewhat more normal or regenerating liver, and everything else around it has necrosed and collapsed. This was a woman who came in, again, acute liver failure of unknown etiology with approximately 1 to 2 weeks of symptoms, very abnormal liver function studies. She happened to have a CT and an ultrasound. Right before she had had the CT, and that's why they did it, she had undergone a liver biopsy, and there was a very small perihepatic hematoma here, no big hematoma in the liver. The liver was maybe a little bit heterogeneous. All of this gray around the enhancing vascular structures is periportal edema. Her ultrasound showed, even better than the CT, a wavy, minimally nodular contour. You can see this is the little hematoma that she had, kind of hypoechoic, not terribly heterogeneous. She had a liver transplant 2 days later with a small liver and a significant amount of necrosis with some very mild evolving fibrosis. The liver nodularity in fulminant liver failure correlates with the length of the illness. The longer the patient is sick, so as you get into the late acute phase and the subacute phase, the liver nodularity becomes greater and greater. Initially, it may be fine and diffuse, and then it becomes very macronodular. The key thing here is that this nodularity is not due to cirrhosis, and this is crucial. If you're presented with a patient and the clinicians tell you the patient is in acute liver failure and you come across a nodular contour, do not immediately say this is cirrhosis. Just report it as a nodular contour. The problem here is that if they think the patient has underlying chronic liver disease and cirrhosis, the transplant priority for the patient will be lower. If it's just acute liver failure with submassive necrosis, they will be higher on the list. Remember again, the pathology for these patients who are in the later stages are alternating areas of focal and confluent regenerating nodules mixed with areas of necrosis. The key thing here is these patients do not have significant fibrosis. And given these large islands of regeneration, we really don't know whether those patients might have a greater potential for overall regeneration and not need a transplant. That's a hard thing to be able to study. There is, in addition to cirrhosis, there is a differential of nodular livers which aren't cirrhotic to keep in mind. Metastases can cause this, treated metastases, sarcoidosis, Chiari, and pseudomyxoma peritonei. So these are other etiologies to keep in mind for a nodular contour that is not cirrhosis. Let's look at some of these patients. This was a patient who came into us through one of our other community hospitals, and the initial imaging, if you look back at it, was interpreted as cirrhosis. This is the appearance of the liver. It was small, clearly a nodular contour, very heterogeneous, highish velocities in the hepatic artery, normal portal venous flow. The patient also had CT, and these are the non-contrast, arterial, and delayed phases, and it was also interpreted as cirrhosis. You can see the liver contour is nodular, there is atrophy of the liver, and it's not strange that somebody would think of it as cirrhosis, which is so much more common than acute fulminant liver failure. Here's another patient who had acute liver failure of unknown etiology. We first imaged the patient somewhere in the acute range when they presented in the 2 to 3 weeks after the initial insult. The liver had a very abnormal appearance, ill-defined areas of increased echogenicity alternating with hypoechoic areas. And if you look with high frequency, the contour of the liver is nodular. Around the portal triads, there's increased echogenicity, and this is periportal edema. The patient had a contrast CT, and you can see there are large, ill-defined areas, somewhat confluent, that are hypodense, and other areas slightly more hyperdense. 2 weeks later, the patient was still with us, and more imaging was done with both ultrasound and CT, and this shows exactly what can happen very, very rapidly. Remember again, these areas are probably the normal areas of liver, slightly ill-defined. By the 2 weeks later, the echogenic areas are now much more discrete, rounded, and lobulated, alternating with hypoechoic areas. The liver has shrunk even more, and the contour is extremely nodular, well visualized because of all of the ascites around it. On CT, again, you can see the higher density nodules correspond to the hyperechogenic nodules on ultrasound, with alternating low density areas and ascites. Essentially, the low density areas and the low echogenicity areas are the necrotic regions in this patient, and the spleen is getting bigger and bigger. There are small pleural effusions as well. There was no cirrhosis when this patient went on to liver transplant. There are not a lot of studies that look at these patients, but this is one of them not too long ago in the clinical literature, in which they just retrospectively reviewed their 46 patients who presented with acute fulminant liver failure. Most of the imaging in these patients was ultrasound. The next most common imaging study was CT. The majority of them had some abnormality, but the majority of those abnormalities were pretty nonspecific. Ascites was probably the most common thing, as you can see here. A few patients had hepatofugal flow. There was a chunk of patients, about a quarter, who had a nodular surface, and as we've learned, those are going to be the patients who had a longer range of symptoms. The etiologies in their group are, as you can see here, with the acetaminophen being the most common, though there were quite a number of idiopathics and other etiologies, and most of the patients had necrosis on their explants. The conclusion of the paper was that imaging and explant pathology depend very much on the timing of presentation and obviously when the transplant is done. Again, they found what is in the literature, that acetaminophen toxic patients are the most common to present in the hyperacute stage, will have a relatively normal liver, and often proceed quite rapidly to transplant. Now let's turn to some other very specific etiologies of acute liver failure and see what they look like. This is a patient who received a liver transplant, had chronic liver disease, got their liver transplant, and we do an immediate post-transplant imaging study. On that, the liver looked fine in grayscale. The arterial waveforms were a bit high resistance, which is not uncommon. The velocities were low normal, as you can see, at 43 centimeters per second. We always imaged the splenic artery as an internal control, which had a much higher velocity and lower resistive index. We had trouble finding intrahepatic arterial flow, and we're just able to get little spikes of flow. We sometimes see that when the liver is quite edematous, so we were not initially concerned. By the second day, when the patient was not doing well and the liver enzymes were becoming increasingly abnormal, we had increasing difficulty finding arterial flow. You can see in this cine clip, there are little blips of the hepatic artery right near the portal vein there, so we could see it in color. It was very high resistance flow, as you can see on the images on the left, and we had increasing trouble finding hepatic arterial flow in the liver. Otherwise, the liver looked fine, and the portal and hepatic venous flow was also fine. As the day progressed, the patient worsened. We were asked to image again. By now, we were having lower velocities, high resistance arterial flow in the liver. It was very difficult to find the arterial flow, again, compared to the splenic artery. And now the liver was starting to subtly appear abnormal. As you can see, there is increasing bright echogenicity around the portal triads. There was some pleural fluid and slightly more ascites. And this is a cine clip of the liver that allows you to see brighter echoes around the portal veins consistent with periportal edema. So nothing very specific, but what was happening was the patient was clinically deteriorating dramatically, and this was felt to be primary graft failure. The patient needed an urgent retransplant and received one within a day. And on the explant, there was hepatocanicular cholestasis, focal ductal cholestasis, as has been described in primary graft non-function. This is a very uncommon thing, fortunately, that's thought to be some type of humoral antibody-mediated rejection. Essentially, it is the acute onset of liver failure without hepatic arterial thrombosis immediately after liver transplant. So it's a very specific group of patients, those who receive a liver transplant and essentially immediate liver failure. They have encephalopathy, et cetera, just as the other patients who come in have it, and they have multi-organ failure. Typically, they die if they're unable to be retransplanted. This is in distinction to patients who immediately have hepatic artery thrombosis, as in this case. This is the first ultrasound after transplant, 8 hours after transplantation. We were unable to find any hepatic arterial flow. This is the portal vein. There was no flow. By this point, the liver was already quite heterogeneous, islands that are hypoechoic alternating with hyperechoic. This is the same pattern that you're seeing here. The patient immediately went back to the operating room where an arterial thrombectomy was performed, which was able to reestablish the patient's flow, and that was fine. These are a series of CT scans at day 11, 16, and 2 months. Fortunately, the right lobe was preserved, but you can see that the left lobe infarcted and over time collapsed down. The patient had enough right lobe to survive. So this is not fulminant liver failure from primary graft dysfunction, non-function. This is what happens when there is an immediate thrombosis. Acute liver failure can, in occasional circumstances, occur from trauma. This patient had a gunshot wound to the inferior aspect of the right lobe of the liver, which also involved the right kidney and the head of the pancreas. The patient had no imaging and went immediately to the operating room where part of the right lobe of the liver was resected. Subsequently, the patient was not doing well and had CT and ultrasound. On CT, you can see the remainder of the right lobe had large areas that were poorly enhancing, thought to be ischemic. Similarly, on ultrasound, a large hypoechoic area of the liver with alternating echogenicity more normal, just as similar to the other patients. The hepatic artery was a little bit odd. It was kind of parvus tardus in this patient. What happened was that there was progressive infarction of the right lobe due to a blast effect. So the bullet didn't go through this piece of liver, but the effect, the trauma to the liver from shaking it up from that bullet going through essentially infarcted that portion of the liver, and the patient went on to have a complete right hepatectomy. At this point, the only thing that the patient had was the left lobe. And not surprisingly, that started to show signs of ischemia, alternating areas of increased echogenicity and decreased echogenicity. And you can see that here. The contour was still smooth. At this point, the patient was in acute liver failure and was listed for a transplant. Fortunately, this was an otherwise healthy young person, and the left lobe went on to hypertrophy. The patient did not need a liver transplant and survived. Acute liver failure can occasionally be due to malignancy. This was an unusual case transferred to our hospital with the diagnosis of acute liver failure, which the patient was in clinically, and we received the patient having, the other institution told us that the patient had chronic Chiari syndrome. This was our ultrasound, and we didn't find any findings of Chiari syndrome. There was hepatofugal flow in the portal vein, and the hepatic veins and the IVC were open. What we did see was a very, very abnormal appearance of the liver. The right lobe was shrunken and had these large areas of calcification and shadowing. The left lobe looked large and much more normal. There was ascites. This was a CT that came with the patient, and you can see that the right lobe was essentially completely contracted. The part that wasn't calcified was odd in its enhancement, and the left lobe had hypertrophied. So we didn't at this point know anything about what was going on in the right lobe. The patient was in acute liver failure and received a transplant. The explant showed that this patient had something called an epithelioid angiosarcoma that had diffusely involved the liver, even the left lobe, and that the right lobe was shrunken down, as you can see here, with some residual non-neoplastic left lobe. As I mentioned, this is a very unusual cause of acute liver failure. As far as what kinds of malignancies cause it, they can be the hematologic malignancies that cause it by diffuse infiltration, such as lymphoma or leukemia, and they go on to cause massive hepatocyte necrosis. The one other tumor that causes it is an angiosarcoma, as in our case, which is a very rare primary liver tumor, which is highly vascular and just causes necrosis everywhere. So those calcifications were due to necrotic regions of the liver. It's probably a multifactorial cause of liver failure due both to the tumor and to the vascular necrosis. Another cause of liver failure can present with acute liver failure, and one in which imaging can make a big difference as far as making the diagnosis, is Budd-Chiari syndrome, which is hepatic vein and often IVC thrombosis and narrowing. This patient came with, in the postpartum state with acute liver failure. This is the spleen. The liver was moderately normal to large in size, somewhat heterogeneous, hypo and hyperechoic, and once again the small gallbladder with a edematous wall. However, in this situation, the Doppler was very, very helpful. The IVC in this patient was obliterated. We could not even find it, and a little piece here that showed up in the lower liver was fed by Collaterals from portal vein, but there was no IVC going through to the heart. This same patient went on to have CT, and these are the arterial and portal venous phases, which show very classic findings of Budd-Chiari syndrome. The liver was large, edematous, poorly enhancing in the arterial phase, poorly enhancing in the portal phase, other than some areas such as the caudate lobe, which had some blood supply. The image that you see on the right is an injection of the IVC through the heart. This is the catheter, and you should normally see the IVC and flow going back into the hepatic veins. All you see is this tangle of tiny, funny vessels here, which is the classic finding in Budd-Chiari syndrome. These are all that's left of the little hepatic veins which open up and essentially makes the diagnosis of Budd-Chiari. This is a 39-year-old patient who had Behçet syndrome and presented with acute liver failure. The liver was somewhat large here, and nobody had suspected the possibility of Budd-Chiari. This is the left hepatic vein filled with thrombus. This is the IVC, partially thrombosed, small gallbladder again. This patient had CT with similar findings. When the venogram was performed, there were some normal hepatic veins in the right lobe of the liver, none in the left, and this is the marked narrowing of the inferior vena cava, which wasn't completely thrombosed. Fortunately, this patient recovered from the acute incident and did not need a liver transplant. Came back 2 years later, and you can see that the inferior vena cava did completely thrombose in the liver. There were numerous collaterals. We saw some of them in the anterior abdominal wall, and you can see them here. But the liver survived. Budd-Chiari syndrome can be a cause of hyperacute and acute liver failure. There are a variety of causes, as you can see here. Imaging is different, and you can make this diagnosis with ultrasound and other imaging, as I've shown you here. Catheter venography shows that spider web appearance of hepatic vessels in the parenchyma. Just a few other issues to consider before we finish. There are some patients who present with acute viral hepatitis. They have very abnormal liver functions and they are jaundiced, but typically do not develop encephalopathy. As far as imaging goes, they overlap with the patients with the hyperacute fulminant liver failure, so they may have a slightly hypoechoic liver, as you can see here. These are some lymph nodes, and often the gallbladder is small and edematous. It's the clinical findings that allow us to separate these patients from those with true acute fulminant liver failure. Sometimes, as I mentioned, there are patients with a liver that looks cirrhotic and it's not cirrhosis, And in addition, it may not be acute liver failure. So just to reiterate that, this patient who had rather abnormal liver function studies, but not acutely so, had no known history of liver disease and came looking like this. The liver contour was slightly nodular, very heterogeneous liver, as you can see here. Vessels were open. As you can see in the CT scan, this is a rather nodular liver and heterogeneous. There are some mass-like areas, but it wouldn't be an unusual thing to call this cirrhosis. And that was certainly contemplated in this patient. This is an octreotide scan, and the entire liver lit up in this patient. And what we're dealing with here is metastatic carcinoid, and this causes, it's one of the metastatic lesions that is known to cause something called pseudocirrhosis. There's the tumor is all over in here, and it causes the contour of the liver to be somewhat nodular. And often in the routine imaging of the liver in the portal venous phase, it's very hard to actually see the discrete masses. They're better seen in the arterial phase, which isn't always done, and you can mistake this for a cirrhotic heterogeneous liver. Lastly, there are patients who present in acute fulminant liver failure who happen to have some chronic underlying liver disease, and we're learning more and more about these patients. So these are people who have cirrhosis and then acutely decompensate and have multi-organ failure. This is a clinical diagnosis rather than an imaging diagnosis. We will see chronic liver failure in these patients, and you can begin to understand that it might be difficult to differentiate these patients from those with subacute fulminant liver failure. They often have a high mortality if they do not receive a liver transplant, and they are put fairly high on the transplant list, though not quite as high as the patients who present with fulminant liver failure without underlying cirrhosis. Generally speaking, there's some precipitating event, such as sepsis or surgery, that puts these patients into fulminant liver failure. So, in conclusion, what have we learned? The entity of acute fulminant liver failure is relatively rare, and you may not, depending on where you practice and the center in which you are, see that many cases of it. The clinical history is exceedingly important. We need to know the length of the patient's symptoms. Of course, unfortunately, that may be somewhat unreliable. Biopsy can be performed in these patients and would be very helpful, but is often very hazardous if they have a great coagulopathy. Imaging, when performed, is usually done with ultrasound if the patient is very ill and in the intensive care unit. The key thing for ultrasound is, does this look acute or chronic? And remember, patients with the hyperacute liver failure will have a smooth surface, and whether or not we can make the diagnosis of the actual clinical syndrome doesn't matter. Our job is to tell the clinicians that the liver surface is smooth and this does not look like cirrhosis. The problem for imaging is those patients in the acute and subacute phases, the liver can become very nodular and very abnormal and simulate cirrhosis. And you may not be able to tell the difference. Just be honest with the clinicians and they will understand. There are other findings, as you know, that you can see, and those are the findings of liver failure and portal hypertension. The other thing to think about when imaging these patients is, can we find an identifiable cause of acute liver failure? That would be a minority of patients and would be something like a Budd-Chiari syndrome, metastases, or a primary tumor. Thank you.